In this lecture, we are going to discuss the pharmacological treatment of myocardial infarctions. Our focus is going to be able to relate the pathophysiology of a myocardial infarction to the pharmacological treatment, utilize the nursing process to deliver safe and effective pharmacological treatment to a patient who has had an MI, and specifically discuss the drugs that are used to treat a myocardial infarction. So before we talk about the medications, we have to first look back on the pathophysiology of what happens in a myocardial infarction. And so we know that there are a couple different ways. There can either be a thrombus formation or a plaque rupture. And as you remember, with somebody who's maybe got atherosclerotic coronary artery syndrome, or over time they've had that plaque buildup, there can be a couple different things that can happen. Around that plaque, you can get a thrombus that will form, and then that blood clot can then travel to the heart, or maybe not necessarily a blood clot, but a piece of that plaque can rupture or break loose, and then that piece of plaque is then what goes to the heart. And what happens is, whether it be blood or plaque, that has traveled to the heart then will decrease oxygen supply to the cardiac tissue, which can then result in death to the tissue from the situation. But it can greatly depend on the amount of occlusion, the length of time it is occluded, and if you remember, we talked about that coronary collateral blood flow. So especially those that have had atherosclerotic coronary syndrome, for years their body has tried to compensate and has created these little small branches or little outlets off the main vessel to supply that heart with additional oxygen. So for those that have maybe had this long time health issue, their body might be able to compensate a little bit longer with that collateral blood flow, whereas somebody who maybe doesn't have that, it could result in greater death to that cardiac tissue. So when we think about the nursing process with our individuals that are suffering a MI, first thing when we think about the assessment, and the cardinal characteristics is that substernal chest pain that has radiation, or it may not. It could just be substernal chest pain. And when we think about that radiation, that can be the left arm, the neck, jaw, upper back. This should be pain that doesn't have a precipitating factor. You see this more commonly in the morning as well with these assessments. EKG changes, we know that we look for ST segment elevation, also known as a STEMI, which just means ST segment elevation, myocardial infarction. So that is one thing that we're looking for on the EKG. As you guys also are aware and remember, a lot of individuals may not have that chest pain, and especially like the elderly or those that are diabetic might not have that chest pain, but they might then have the diaphoresis, the GI discomfort, nausea, vomiting, syncopal episodes, shortness of breath, that kind of thing. Another thing to remember is also women might present a little bit differently. They usually have more like jaw and neck pain, more so than substernal chest pain, and a lot of times women can also be more stubborn before they come in, so that's something to take into consideration too. Assessment wise, labs, you're going to be looking at the biomarkers. Troponin is the cardinal lab that we're wanting to look at, but they'll also do the serial CKMB, that kind of thing as well. But that troponin, they're going to look at that and really try to trend that and see where that peak in the troponin level is, and make sure that it starts going down. When we think about nursing diagnosis, the priority nursing diagnosis is that decreased perfusion that's going on, but then you can also think about the pain and anxiety that's going on with that patient that you need to treat as well. As you continue to look at the nursing process in terms of planning, our goals are to increase the oxygen supply and decrease oxygen demand. We also want to decrease pain and anxiety, which by doing so will help increase oxygen supply and decrease demand. And then obviously our interventions are going to be pharmacological and non-pharmacological, which we'll talk about later in this lecture. As we implement, we're constantly wanting to evaluate our oxygen levels, EKG, their pain, their biomarkers, how is that medication working, how is their body responding to that. And obviously during our entire implementation evaluation process, we're wanting to monitor very closely because they obviously have the risk to go into cardiac arrest, so they're very unstable at this point and require very close monitoring. So the actual pharmacological treatment of an MI, you guys have heard me say this before, and it's an easy mnemonic to remember, is MONA, which is morphine, oxygen, nitrates, and aspirin. Not necessarily in that order, and it can also be a morphine derivative, but then also there are beta blockers and thrombolytic agents, which we'll look at each one. So a priority intervention that we're going to do as nurses is obviously administer O2. Easy, quick, simple. Get that on them as quick as possible. You want to keep that oxygen level at least 95% or greater, and administer it for at least the first 6 hours post MI. And it's one of those things that we really want to over saturate them per se with oxygen, just to decrease that demand on the heart and increase that supply. The utilization of nitrates. First thing, and I think this is important to note, if they're at the hospital or if they have not received nitro yet, if we can get IV access before giving it, that is ideal, just because we know that it vasodilates and it can drop that blood pressure quite a bit, so that can then make it more difficult to get an IV later on, and especially if they were to need IV nitro or that kind of thing. So if we can get IV access first, that's ideal. Now, sublingual nitroglycerin, they've started changing the guidelines on this a little bit. It used to always just be, if they had it, to take 15 minutes apart, monitoring their pain, lay down and everything when they take it, and then after the third one, if they were still having chest pain, to call 911. But they're really getting away from waiting so much. Now, if somebody who's got a history of angina or that kind of thing, don't just start calling 911. But if it's somebody that this is acute onset, this is just different, they can take that nitro, but to just go ahead and start calling for help much earlier in the process. If they're in the hospital, we're going to give it following the normal guidelines, giving the 3. We want to monitor their chest pain, their blood pressure very closely, and then see how they respond. If more extreme need of nitro is there, then we can do IV nitroglycerin, and we can do this for those that have continuous chest pain in the middle of that MI. Maybe they're hypertensive or they have pulmonary congestion, would all be good reasons for the utilization of IV nitroglycerin. Reasons not to use nitro would be if their blood pressure is less than 90 systolic, or if they're 30 below their baseline, their heart rate's less than 50 or greater than 100. There is the suspect that there's an RV or a right ventricle infarct, and if someone's maybe took a phosphodiesterase inhibitor for erectile dysfunction within the last 24 hours, just because of that vasodilation property. So the next medication we have to think about is aspirin. Ideally, we would hope that they've taken it pre-hospital at home, but if they didn't have aspirin or at home, then either EMT, paramedic, whoever shows up if they call 911, would then be giving them aspirin. And the recommendation is, at least 162 to 325 milligrams of the chewable aspirin. Research has shown that the buccal absorption is much more rapid than that of taking an enteric coated. So ideally, we would really prefer that they have that chewable on board. And the way that aspirin works is by inhibiting thromboxane A2, which is going to decrease the aggregation of platelets. So if it is a clot that has formed, then that's going to decrease buildup on that clot, making it worse, but it's also going to decrease vasoconstriction, so it's also just going to help just a little bit in terms of allowing more blood to flow past that clot as well. So we've talked about how in an MI, obviously they're having pain, and that pain is the result of damage being done, tissue death in the heart. But one thing that's important to think about is when your body is in pain, one of the responses is to release catecholamines, and what this can do is then increase the damage to the myocardium, so it becomes a vicious cycle. If we don't treat the pain, and the body's going to release more catecholamines, and then those catecholamines will then do more damage to the heart. So we have to get the pain under control, and that's why morphine becomes so important in treating that pain. So what we think about with this is not only does it help decrease pain and decrease the release of catecholamines, but morphine has arterial and venous vasodilation properties, so it's going to help decrease oxygen demand. It's going to decrease preload on the heart, decrease afterload on the heart. So it's going to decrease oxygen demand and really kind of help with better utilization of the oxygen that is there. So what we want to do is we want to administer morphine IV, usually 2 to 4 milligrams initially, and then that can be adjusted every 5 to 15 minutes depending on their level of pain that they have. Obviously, we do have to think about, though, with morphine, the side effects. So they can become hypotensive because it has a vasodilation property. And one of the biggest things we also think about is how morphine can have that respiratory depression. So we have to monitor that carefully. Also, we have to remember that morphine can sometimes have the side effect of causing somebody to have nausea and vomiting. If they already had that maybe coming in with the MI, we do really need to keep an eye on that. But then there's also the lethargy that can even have some hallucinatory properties as well. So those would all be things we would watch with morphine. So it's recommended that you do immediate administration of beta blockers. If they are having a tachyarrhythmia or are hypertensive, it's really recommended that it be given IV, although it can be done PO. But the reason we want to do this is because we know that it's going to decrease the heart rate. It decreases the contractility of the heart, so it's going to help with that, the workload of the heart, and decrease that. It's going to help decrease the oxygen demand. But one of the biggest things is it decreases the risk of lethal arrhythmias related to the coronary system, or the way that the body is working in that time frame. So it's very important that we get this on board just to decrease the risk of those lethal cardiac arrhythmias. So the goal with someone who's having an MI, and when they come through the ERs, we would like for them to be in the cath lab, getting an angio, getting that stent or a balloon or whatever done. Within 30 minutes, we want to have them in the cath lab from the time they reach the ER for that reperfusion to the heart. That's going to be the best outcome for them. You're also going to see they're going to do thrombolytic agents. So, this might just be loading dose of Plavix if they can get them into the cath lab pretty quick. If there's a delay or something like that, they might then start TPA. So it's really just going to depend on the situation with that patient, but obviously that reperfusion to that cardiac tissue is the goal. So then finally, what we want to talk about is just the non-pharmacological treatment that we can do with these individuals. So we want to provide them with a calm, quiet environment. We want to decrease their anxiety, reassure the patient, explain what you're doing, try to position them in a comfortable position. So all of these things that we can do that would then decrease anxiety, decrease pain, keep them calm, because that in itself will help decrease the demand on the heart and decrease that oxygen demand as well. So in summary, we can look at how we related the pathophysiology of an MI to the pharmacological treatment, how to utilize the nursing process to deliver safe and effective pharmacological treatment, and then the actual drugs that would be used to treat an MI.